Hello
Hello.
there. Hi. Okay. Welcome
Okay.
to From Skirts to Scrubs. I'm Charlotte,
And I'm Alicia.
and we are two OBGYN residents trying to figure out our place in medicine by looking to the past and to current events to try and understand the impact they have on us as women in medicine and as women in general.
Yes, and you can find or follow us on social media. We have an Instagram and a TikTok, which are both at From Skirts to Scrubs. We have a Twitter, which is at FSTS_podcast. And you can check out our website for more information on our show notes, sources, merch, and more. And that is from skirtstoscrubs.com.
Yeah, you can also subscribe and leave a rating and review. Apple Podcasts and Spotify are great places to do that. And we also now post on YouTube and have live videos of what we're doing exactly right now. So be sure to check that out and give us a like and subscribe there as well.
Yeah. I cannot believe we're residents.
That
crazy.
Really threw me off. Guys, if anyone's a previous listener, you know that we usually say that we're medical students, but this is our first episode where we are both OBGYN residents. So that's crazy. That means we've been doing this podcast for 4 years since we started it before medical school.
It's true.
And now we're residents. I can't believe it, to be honest.
I know. We live in the same city now.
And
we hung out yesterday.
Literally hung out yesterday. I was thinking about that when I was getting ready for the podcast. I was like, I don't think I've ever seen or talked to Alicia 2 days in a row like this. Like,
I know. We're spoiled now.
It's very exciting. We are spoiled in the best way.
It's true.
Yeah.
But today we are going to dive into a very appropriate episode for now being OBGYN residents. We are going to be talking about the history of the VBAC, or also known as the vaginal birth after cesarean. And before I get too much into it, Char, do you want to tell me what you know about the VBAC? Like, what are they?
Yeah. I feel like I don't know a bunch, but I do know that if you have a C-section, which is when they cut the baby out of you, you can either in your next pregnancy have another C-section or try for a vaginal birth. So a VBAC is when you have a successful vaginal birth after C-section, and you kind of come to this decision of if you should have a trial of labor after C-section or not with your doctor, and you talk about like the risks and the benefits and if you're a good candidate or not. And I think you're probably going to talk about today is like the VBAC like calculator that helps people determine if you're a good candidate or not, because sometimes it can be really dangerous for you to try for a vaginal birth after C-section. And so it really depends like patient to patient on what you're supposed to do. So I'm guessing today we're going to talk about like how those decisions are made and what it's like to have vaginal birth after C-section, all that stuff. So that's all I know.
That's great.
Generally,
that's a good place to start.
Yeah.
And yeah, we're going to be talking about that. We're going to be talking about the calculator, some of the history, and like just kind of a lot. It's a good mix. So let's just get into it.
Cool. Let's do it.
All right. So to get right into it, what is a VBAC? What's the situation there? You did a great job explaining. I will give a quick summary and then go from there. So when someone is pregnant and has had a C-section in the past, they have 2 options for giving birth for their next child that they are currently pregnant with. The first option is to have a repeat C-section, but the other is to try to have that baby vaginally. Now you may be wondering, oh, but Alicia, why would the person not be able to have the baby vaginally? Like, why is that a big deal? Who even cares? Oh, great question. I feel like a good way to think about it is like, imagine you have an elastic bouncy ball. And if you have this elastic bouncy ball and it tears in one spot, even if you were to fix it in that one spot with a patch, if you blew up the bouncy ball again, there'd be a higher chance of that ball bursting or tearing at that spot because that patch is just a weaker area. And that's the same thing that happens when you have a C-section scar. So when you have a C-section, they cut through the abdomen, they cut through the tissue and like everything. And most importantly, they cut through the uterus to get the baby out. That's the whole point. But obviously what happens when you have a big cut that like comes together and it has to heal, you get a scar there. And especially because we suture and we like bring such like dense tissue together, the scars can be pretty hefty. And if there's a scar left behind, that is essentially your weak spot on your uterus.
Mm-hmm.
And so there's that. It's essentially the patch on the bouncy ball. And in the next pregnancy that you have after you've had a C-section, same thing. Your uterus expands and that scarred area is just more likely to tear. And that risk especially goes up during the labor process, like a vaginal delivery, or when you're pushing out a baby, there is an even higher likelihood that you might accidentally tear the uterus in that spot because there's so much pressure from that muscle contracting and pushing down, pushing that baby out.
Mm-hmm.
And so that's why it's dangerous to potentially have a vaginal birth and to try to push out a baby after you've had a previous C-section because of that scarring and because of that weaker spot there.
Yes.
So then why don't we just do another C-section and get the baby out? And we do. We do that. So
we do
we do a lot.
Yeah.
So according to the CDC, the rate of repeat C-sections is upwards of 80%. So most people who have had a C-section before have a C-section again. But why would we not want everyone to just have repeat C-sections, Charlotte?
Because a C-section is a major abdominal surgery, comes with its own risks. Every time you have a C-section, you're going to have more scar tissue in your abdomen, which is very dangerous if you have any future surgeries, not just like C-sections, but if you have any surgery to your abdomen, you've had a previous C-section, that general surgeon's going to be like, oh God, because the scar tissue is everywhere and it can get bad and you can bleed a lot more because of all the scar tissue tearing off your tissue and just like increases your complication rate, basically.
Yes, absolutely. And so we try to keep C-section rates low at a baseline. I mean, we're sometimes successful, sometimes not. But then to try to keep that rate low for the same reasons, even on a repeat C-section, is something that OBGYNs are cognizant of and do try to work towards.
Yeah. I think a lot of people think that OBs like want to push moms to C-sections because they get paid more, but I'm pretty sure insurance covers it all exactly the same. Like when you're pregnant, like the insurance, the way it covers it for your OB is like one package. So it's just like a whole package of you get paid this much for this person being pregnant. It doesn't matter if you get a C-section or vaginal birth. So they're pushing you to C-section. It's for your safety, not for their monetary benefit, I guess.
Yes. I believe this. I'm not 100% sure.
I'm pretty sure that's how that works, but we'll learn more soon, obviously.
We are about to find out, yeah. But essentially, if you're pregnant and you have had a C-section before, the remaining people who aren't going immediately to section again are going to have what's called a trial of labor after cesarean, or in other words, a TOLAC. That's what we call them. And if you successfully TOLAC and have a vaginal delivery after you do that, that's considered a VBAC. And so the TOLAC is the trial, the VBAC is the success. And it's just semantics. It's not a big deal, but that's kind of what we're talking about. And along a similar vein, what are some of the benefits of VBAC?
I'm guessing that you don't have to go through major abdominal surgery.
Yep.
And there's benefits to having vaginal birth, like for the baby. Like I'm pretty sure like lung development's better when you have vaginal birth. Your gut health is better if you have vaginal birth, stuff like that. So
yeah,
like neonatal benefits.
Neonatal benefits, and then all the benefits that come with not having surgery. So like shorter recovery periods, lower risk of infection, less blood loss, that kind of stuff. But it's important that the person who is trying to have a VBAC is a good candidate for it. And this kind of gets into what Charlotte's talking about before of who are good candidates, how do we use a VBAC calculator, that kind of stuff. And so I'll just generally go over like who are the best candidates for VBAC and who are like okay, decent candidates. So the best candidates for VBACs are people who had a previous C-section with a horizontal incision on the uterus. So some C-sections have straight up and down incisions, but most of them are horizontal. And so the best candidates for VBAC will have had a horizontal incision before. Additionally, what makes people a good candidate is when people have had a successful vaginal birth before. So say your first baby, you delivered vaginally, but then your second baby, you had a VBAC. Would you be a good candidate to deliver vaginally after that C-section? Yes, you would, because you've had a successful vaginal birth before. And then also people who had their past C-sections for reasons that don't typically recur. So what that means is like you can get C-sections for lots of reasons, but if the reason that you got a C-section before is because your baby was feet first or breech, that would make you a better candidate for a potential vaginal delivery in your next pregnancy, because it means that the reason you didn't get a C-section, or the reason you got a C-section before, isn't because your body for some reason can't tolerate
delivery or something.
can't tolerate vaginal births. So those
That
are
makes
like the
sense.
best candidates, but that does not mean that if you don't have those things, or you have some variation of those things, that you would be a bad candidate for a VBAC, or you wouldn't have a successful one. 60 to 80% of TOLACs, or trials of labor, are actually successful. And the decision to try is really between the patient and their OBGYN, and it should be a partnership between those two and long discussions about why and what the best option is. And so I hope you come out of this knowing that if you are someone who is thinking about having a child or bearing a child, or know someone who's doing that and is thinking about delivery options, and you've had a C-section before, talk to your doctor. You could very possibly have a successful vaginal birth even after. All right. So that was the overview of VBACs in general and TOLACs and some vocabulary to review. But now let's dive into the history, because I feel like the history is interesting and probably something we don't know that much about.
Yeah, I don't know anything.
Yeah. And I wanted to remind us a little bit about the history of the C-section in general, and then also tie that into the history of the VBAC and to the history of the factors that make up the VBAC calculator, which we are going to talk about.
Cool.
Because it is an interesting history, and there's a lot of systemic racism and individual racism that comes into play that is worth discussing. Not cool at all, but important to talk about. So to start, the first C-sections, to remind us, were done in the 1500s and 1600s, but they weren't successful consistently until around the early 1900s. And actually, I found this kind of funny article from this doctor named Dr. Edwin Cragen from the New York Medical Journal from 1916. So this is like a true primary literature article. And in this article, he talks about the pros and cons of this new technique called the C-section that had finally, by 1916, become consistently safe. And one particularly funny thing he says, as he's talking about forceps and like all these different things that relate to vaginal birth, he's talking particularly about using forceps to deliver, and like when that's a good idea, when you go to C-section, blah, blah, blah. And this is a scientific journal, by the way, that he's writing this in. He literally is talking about using forceps and says, quote, "There is a Scylla and Charybdis in the use of forceps in obstetrics. We might call the Scylla too early in the application of the forceps, when the cervix is not dilated enough, and Charybdis is when it's too late." I'm like, okay, man, you do not need to bring up Greek mythology when we're talking about like delivering babies.
Wait, for a second,
Like,
I was like, who is Scylla and Charybdis? What is that? The Sea of Monsters?
Yeah. It's literally the like monsters from like the Odyssey.
Yeah, like the one that like plucks the sailors off the ship, and the other
sailors
one
off
like
the boat, and then one that's like
one that's
a
whirlpool. Yeah, isn't Scylla? Is that the one that eats the sailors?
Yeah.
You know, I
But
just
basically he's
read
like
Percy Jackson,
using
so
no, I know. But it's so confusing because he's like comparing I'm like, this is a scientific journal, my guy. Like
but also
I
like
don't
what
even
is the
know.
analogy? Like if your Scylla's too early
And Charybdis is too late. Like I don't know. I think he's trying to be like neither is good.
Oh, yeah, I mean, yeah, I guess.
Neither is
This is
good.
such
He
a
was
bad
right.
analogy.
It was such a weird analogy and like a random time to be talking
Yeah.
about it. And
He's like,
scientific-
everyone has read the Odyssey. They know what's up. Like,
it just
literature
really goes to
classes
show.
are on it. Those ninth graders, I know.
I'm like, oh, it just goes to show how you like these white men can wax poetic and like no one cared.
What? Okay. I
Yeah.
didn't even know at first what that was. And I was like, I've read Greek mythology so many times.
I know.
Oh, man.
That just goes to show how many people are actually reading these articles. But
Yeah.
I was one of them.
All these years later. Yes.
I know.
Little
Yeah.
Alicia.
I know. Sitting in Harold Washington Library reading these articles. But basically, that was just like a weird tangent that I was like, this is so random. But in an article from the American Journal of OBGYN from 1927, there is an article by Dr. Frederick Rice who introduced the idea of trialing labor after C-section. And he showed a sample of patients in which this was successful. So this man, I think he was at Hopkins, and he had like done this small trial where he trialed trialed labor after C-section.
Okay.
But he was able to show that this sample of patients had successful VBACs. However, it wasn't until 1980, so a whole 60-ish years later, that VBACs actually became more popular and more common because professional groups started recommending that people have VBACs after a prior cesarean. And it was actually by the 1990s, so really like pretty recent.
Yeah, it's
that
super recent.
Insurance plans and HMOs in the US actually began requiring VBACs in some cases, not letting women plan repeat surgeries. And so you can kind of imagine like VBACs are not popular. Suddenly in the 80s and 90s, they like skyrocket in popularity. So like everyone's getting VBACs. It's almost like a trend at that point.
Interesting.
Yeah. And it was because the C-section rates were going up like in the 60s and 70s. But then they tried to counter that by increasing the VBAC rate.
Yeah.
And this is important to kind of talk about that switch off, because just like as a background note to remind us all that Black and Hispanic patients had and continue to have higher rates of C-section than their white counterparts. And this is important when we're thinking about the history of the VBAC because, well, I'll get to it in a second. But essentially, VBACs were becoming much more popular in the late 90s, early 2000s. And so C-section rates actually started declining. And one study from the American Journal of Public Health in 1988 found that the rate of C-section increased from 3.4% in 1980 to 6.6% in 1985.
Wow, so it doubled almost in 5 years?
Yeah. Yes.
Wow.
And then the number of VBACs actually peaked in 1998 at 28%. So they really like shot up in the number of VBACs that they were having because it started out like in the single digits probably, and then they like counteracted the C-section rate that was growing. However, as the VBAC became more common, as you can imagine, so did the number of complications. And the most feared complication is one that I kind of alluded to before, where the uterus tears during labor, and that's called uterine rupture.
Yeah. Insert image of baby's hand, like,
oh
the uterus.
My God. I didn't even think about that, but that is one of the most traumatizing pictures in some of our like study materials is like a picture of the uterus and the baby's hands are just like coming out.
Yeah, the baby's like, it's like a horror movie.
Yeah, it's really horrible.
That's a uterine rupture.
That's uterine rupture. You never forget it.
Yeah.
And essentially, because these complication rates like uterine rupture were rising because of just like the sheer number of people getting VBACs, kind of without much thought. It was like a universal, like, oh, everyone should try. Even
There
people
wasn't
who
like
were not
guidelines like today.
exactly,
Gotcha.
even people who were bad candidates were getting VBACs. And so this
Mm,
complication rate skyrocketed. And so then the rate of VBACs dropped like
makes sense.
so quick.
Yeah.
And by 2006, less than the rate of VBAC dropped to less than 1%. And it had
Wow.
been 28% in 1998.
Yeah.
So you can really see that decline.
Mhm.
However, ACOG and other governing bodies in OBGYN, like MFMU, which is the Maternal Fetal Medicine Unit Network, and ACOG, which is, I mentioned, is like one of our governing bodies, the
Mhm.
American College of Obstetrics and Gynecology, they still recognize that the VBAC is a reasonable and safe option for some patients.
Mhm.
And so they made a VBAC calculator. And that was developed in 2007 by the National Institute of Child Health and Human Development and MFMU. And the calculator was designed to help clinicians counsel patients on the likelihood of a successful VBAC after a previous C section. And it considered several individual patient factors that like contributed to this score. And so, can you guess what those factors might have been, Shar, or like any thoughts of what might have gone into the VBAC calculator?
Yeah, I'm pretty sure race was a factor because we're going to talk about that.
Yes.
I'm guessing age. I'm guessing like how many previous pregnancies and like how those deliveries went. Other than that, I don't know, past medical history maybe.
Yeah, that's actually a pretty solid. So
Yeah.
they use age, height, weight, history of
Wait.
vaginal and cesarean deliveries, and then race and ethnicity. And so obviously, big problem, including race and ethnicity in a calculator like this.
Mhm.
Any thoughts about why it's a problem, Shar?
Well, if like Black women are already getting more C-sections, then they're going to be like more people, I guess, candidates for VBAC and being put into the calculator. And then I don't know what the race like part of it did and how it weighed it, but I'm pretty sure it would basically tell women like they couldn't get a VBAC. And a lot of Black women had to get like repeat C-sections, but I don't know why.
Yeah. Yeah, no, I mean that is exactly it. So
Yeah.
essentially, studies found that studies that studied the VBAC calculator found that it was significantly underestimating the success rates of VBACs in Black women.
Mhm.
And so, like you said, more Black women were getting repeat C sections. And a study from the American Journal of OB-GYN by Dr. Shaquila Faulkner and her colleagues found that the calculator would have given 44.6% of Hispanic women and 43.9% of non-Hispanic Black women an unfavorable VBAC score. So that's like almost 50% of marginalized women getting told that they would be recommended to have another cesarean section.
Just based on their race. Like
Yeah,
even
and
if
that's
everything else is the
compared
same. Yeah.
to the 9.5% and 12.1% of the score, like their scores of who would be excluded if you took out race.
Wow. That's crazy.
Yeah.
It's a huge
Like,
difference.
yeah, we drop a lot.
Yeah.
And so obviously this was discouraging women of color from even attempting a VBAC.
Mhm.
And this is, of course, rooted in the history of racism in OB-GYN because the VBAC calculator considered race and ethnicity essentially markers of intrinsic health differences between patients of color and white patients.
Mhm.
So, for example, obstetric researchers found Black women to be, quote, at risk for higher rates of maternal mortality than white women. But the reason was that Black women had higher rates of fetal intolerance of labor, which is actually a kind of subjective measure because
Mhm.
reading fetal heart tracings in many ways is black and white, and then there's a huge gray zone in the middle.
Yeah.
And
you're like, it might be this.
and a lot of times it's out of like an abundance of precaution that a provider will choose to go to C-section or to not.
Yeah.
And it is just interesting to look at labor patterns and how specific they are to different providers and what each individual provider's numbers might look like. But to say that Black women had higher rates of C-section due to fetal intolerance of labor is a product of racism itself and not something inherent about Black patients. Yeah. So TLDR was that the VBAC calculator needed a huge revamp.
Yeah.
And that's what it got. So yeah, the MFMU network published a modified calculator in June of 2021 that replaced race and ethnicity as a risk factor. And so the updated calculator now has all the old things, but then has a new clinical variable, and they replaced race and ethnicity with essentially like whether or not the person is being treated for chronic hypertension.
Interesting.
Yeah.
Why?
I think it's because what they were trying to measure when they were looking at race was higher rates of certain chronic diseases in different racial populations.
Yeah.
And even though that is still a result of racism and like food insecurity and health insecurities, those are still real issues that affect patients of color.
Yeah.
And so to not include it at all, I think would have missed some folks.
Right.
But
just saying like just because of your race.
Yeah. Exactly.
It's like that's incorrect. Like it's based on like where you grew up in like the community that you're in. Which just happens to like be very segregated just because that's how communities are. But that doesn't mean that it's like a direct connection.
Exactly.
Yeah.
Exactly.
So that makes
and
sense.
So as of January of 2023, that calculator is now available for use. So really recent. Like and it all makes sense. Yeah, it all makes sense too, because there was a whole movement in and around, 2020, and with BLM as such a prominent movement at that time, it really forced
made people
everyone to take a look at themselves, including healthcare professionals. And so there was a lot of calculators that ended up having race and ethnicity removed from them. I know that like the kidney, like renal calculating. Yeah, I don't know.
The kidney. Your mom is a nephrologist. Why don't you know?
I know. She would hate this. Sorry, Mom. Don't
GFR,
listen to this.
The GFR calculator. That's what it was.
GFR calculator. That's it. Yeah. VBAC calculator
kidney
was definitely one.
We don't deal with kidneys anymore.
I know, that was embarrassing. That was bad.
Oh, that's funny.
But now the Healthy People goal of 2020. So for background, the Healthy People Initiative is this like 10-year initiative that gets launched by the U.S. Department of Health and Human Services. And they essentially make these like 10-year goals for like what they want health to look like for the American population over the next like 10 years. And they like work on initiatives and projects and fund projects to help make these goals possible. It's actually really cool. They have it like all across specialties. It's not just OB-GYN, of course. But the 2020 goal, so they made this goal in 2010 for 2020, that by 2020 they wanted to increase the VBAC rate from 1% in 2006 to 18.3%.
How do they come up with that? They're like, we need to get better. 18.3, not 18. Not 19, 18.3.
I'm sure it was evidence-based, but I didn't look that into it.
It's just so specific. Like, not 18.2. Like,
no, you're right. It was. And it's unfortunate because we didn't even hit the goal. So, but we did improve it. So rates of VBAC increased from 12.4% to 13.3% just between 2016 and 2018 alone. But we never quite made it to our goal of 18.3%. and actually like low key the C-section rate be rising. But VBACs aren't specifically mentioned in Healthy People 2030. Like I looked
interesting.
to see if they mentioned it, but they didn't. It kind of dropped off. But
did they mention like
check
decreasing C-section rates?
that's the big goal is that their
like,
goal
let's get
is to
ahead of it.
decrease C-section rates. And apparently that's going poorly. I couldn't even get data on what it looks like poorly, like what that means. It just, you can go on to Healthy People 2030 and look up different goals and it'll tell you like going well, going poorly, and the C-section rate currently is going poorly. So
that's interesting. I wonder why like they haven't been able to decrease, like if it's provider based, like you were saying earlier, in their decisions, or like patient decisions, or what, or like general health population's worse, so more C-sections.
I don't know. And I'm curious about how much of it is institution specific, provider specific, like patient desire, because we don't really tend to do C-sections now, even if a patient is like, that is what I want, but they don't have like any indication.
Not
like
recommended.
It is more of a partnership of like, here's all the reasons why we'd recommend to try vaginal birth. And I just don't know. And maybe it's like a cultural difference. I don't know.
That'd be interesting to see.
Yeah. But regardless, the VBAC and its history are long and convoluted and complex. And I tried to distill it down to kind of the TLDR things you should know. But the biggest thing to know leaving this episode is that VBAC is an option. And considering it, if you've had a previous pregnancy and a previous C-section and you're pregnant again, thinking about your delivery plan, knowing that having a vaginal delivery is an option for you, regardless of the C-sections you've had before, just talking to your provider, getting all the information, and making an informed decision about what makes the most sense for you and your lifestyle and your family and your health are the big things that I wanted you to take away from this episode. And I just thought the history was interesting, and thinking about race and racism, and of course how that history is so entrenched in the history of OB-GYN. We would be remiss to not talk about it, but it always comes up.
I think it's interesting because like, yes, the calculator was recently changed for the better, but like the fact that the calculator was made in like the late 1990s, early 2000s, and still had like a race-based aspect that didn't have any evidence-based medicine in it is like a red flag for the profession. And like, it has been changed, which is good, but that doesn't mean that something else couldn't come up in the future where like we also have to change that and like think more deeply about it. So it's a good example of like why we do what we do, and talk about like why we talk about the history. Because if you don't know the history of OBGYN, then how are you going to know that like these are factors that you might not even be thinking about in your own like implicit bias when you're creating these like calculators that guide healthcare and guide your physicians to make decisions?
Yeah, exactly. But if you liked this episode and you want to hear more about VBACs and hear more from us, your two favorite little OB-GYN resident intern
baby
friends,
interns,
you can subscribe to our podcast and leave us a rating and review. Apple Podcasts is the best place for that, but you can also check us out on Spotify and all the other places you get your podcasts.
Yeah, you can also follow us on social media. We have Instagram, Facebook, TikTok, Twitter, everything, and YouTube. And then you can check out our website for more information on show notes, sources, merch, and more at FromSkirtsToScrubs.com. And lastly, here is to the women who have fought for us to be where we are today, and may we do the same for those who come after us.
See you next time.
Yay! Bye, everybody.
Bye.